Good afternoon.
Good afternoon.
And welcome. As Dean of the Frank H. Natter MD School of Medicine at Quinnipiac, I'm delighted to welcome you to our 10th Anniversary Symposium and Celebration. I have to say, it's really wonderful to be here with all of you today, surrounded by our students, staff, faculty, university leaders, hospital partners, and other supporters. So welcome to all who are here, and also a big shout out to some learners who've joined us remotely from Brown University, from RISD, from University of Chicago, and a few other locales. We're so happy to have so many people engaged with us today. As you know, today's symposium honors the legacy of our namesake, Dr. Frank H. Natter, the Michelangelo of medicine. His renowned anatomical illustrations and paintings were crafted with a striking degree of empathy and humanity, and they've inspired generations of healthcare professionals and medical illustrators. And I think that's why it's so fitting that today's symposium is not just about the symposium itself, but also about the juried art exhibit that we've put together. So very excited to celebrate both of those with you. Before getting started, I'd like to recognize our honorary symposium co-chairs, Professor Francois Luck of the Warren Alpert School of Medicine at Brown University, and Dr. Ian Sook of the Johns Hopkins School of Medicine. I'd like to ask them and all of our speakers to please stand and be recognized so that we can give you a big round of applause. And finally, before kicking off today's symposium, we'll begin with a special announcement of the winners of our juried art exhibit held in partnership with the Association of Medical Illustrators, AMI. Please join me in welcoming to the podium Barbara Bergen, Associate Program Director of SCRC, and Assistant Dean Charles Collier, who will share this exciting news with us. Welcome.
Thank you. I just want to begin by thanking everyone who contributed their valuable time, talent, and expertise to help make this exhibit possible. And we're just going to go ahead and I have the pleasure of announcing the winners in the professional artist category. So we have two honorable mentions to start us off. And the first honorable mention goes to Eva May Natividad Gotham for Vitiligo informational poster. The second honorable mention goes to James Perkins for VEGF in wet age-related macular degeneration. And the next award that we're giving out is for third place. And that award goes to Kristen Larson Kyle for patient presentation, inferior peduncular pontine cavernoma. Our second place award goes to Yixin Wu for distribution of the segment of the maxillary artery and open heart surgery. And finally, Best in Show in the professional artist category is awarded to Jennifer Fairman for allergic rhinitis. I just want to turn it over now to Dean Collier. I just wanted to announce the student award winners.
Yes, I have the great pleasure of announcing our student winners. Starting in third place, we have Paulina Naser Saravia. The title is on the slide. For our second place winner, we have Edison. Yeah. Our student category Best in Show goes to Callie Fellow. expected. Let's have a round of applause for all of our winners. All of the winning pieces and entries will be on our third floor, as well as a special exhibit of the Natter display that is in the Edward and Barbara Natter Library through October 8th. So please avail yourselves to really seeing all of these pieces up close and personal. At this time, I'd like to bring to the podium Dr. Lisa Katelyn, our Associate Dean for Faculty Development, to the podium.
Thank you, Charles. Would love for all of our winners who are present and with us today, our student winners, to please stand. And yeah, we're here. Beautiful. Well, welcome everyone. I hope that you are as excited as I am to learn from our distinguished speakers today and expand our thinking about art and medicine. To give you an overview of the day, we have 7 incredible medical illustrators and one who's on Zoom with us. Who'll be giving brief presentations followed by brief question and answer periods. And then at 4 p.m., we'll have a 30-minute break before we kick off our final portion of today's celebration. And at 4:30, we are honored to have Ms. Francine Mary Natter delivering the keynote address, followed by our reception at 5:15 in MNH 105, just over there. And if you would like more information about the 10th anniversary celebration, please use the QR code that's on the program to link to the information page on our website. I'd like to take a moment to thank Dr. Luba Konopacek, our Senior Associate Dean for Education. She worked very hard with Ian, Suk, and Francois Lux, our co-chairs, organized this symposium. She's not able to be here today. She's participating in a special conference. And I know that she would be equally thrilled to introduce all of our wonderful speakers today, including our first speaker and symposium co-chair, Dr. Francois Lux. Dr. Lux is a professor of surgery, pediatrics, and obstetrics and gynecology. I bet there's nobody here who can claim that they are a full professor of 3 clinical departments at the Alfred Medical School of Brown University and the pediatric surgeon-in-chief at Hasbro Children's Hospital. As a medical student, he drew his daily comic strip for several newspapers and later started to illustrate some of his own research publication and then those of colleagues. He firmly believes that all doctors draw, whether to explain medical concepts to patients and families, to teach or to compare notes with colleagues. In his 2023 TEDx talk, Sparks the Limit, he extols the virtues of the visual abstract, combining simple graphics and minimal text to explain complex scientific topics. His recently published book, MedSpeak Illuminated, The Art and Practice of Medical Illustration, grew out of the full semester course in medical illustration he teaches to undergraduate students at Brown University and the Rhode Island School of Design, who are with us today on Zoom. His presentation today is entitled Art Med, the Next Generation.
So thank you so much. I want to first thank Dean Vinal and Dean Konopacek, who could be here for the opportunity of doing this. I think this is an incredible initiative. It's been a year in the making, a little more than that, and so I'm really happy to be here. And what I want to talk about is in a very field that tends to sound like a tricky to talk about art med, the next generation. Those of you who know. I do have a little conflict of interest, as you heard from the public. I did write a book. I'm proud of it. There it is. So, since I'm the first speaker, I figured maybe I should set it up a little bit. So, what does the term vertical illustration evoke? If you can ask anybody in North America, I think they will say the same thing. If you ask anybody in this audience, they have to say Frank Natter, of course. But I think this is a universal concept that when you talk to medical people about medical illustration, they will mention Frank Natter. A number of you may say Vesalius as well. He was a fantastic anatomist, but not really an illustrator. Leonardo da Vinci, definitely, probably the proto-medical illustrator. And then a smaller number of people may mention Max Bradel, who can be considered the father of modern medical illustration. So I'm going to try to set up a little bit about what medical illustration is about and what it isn't. So not every representation in art of a medical topic is necessarily medical illustration. Even though, and this is something I discovered not that long ago, and I don't know how many of you know that, but if you look at the famous Rembrandt portrait of Nicholas Stolp, you'll notice that somebody in the background right there is actually taking notes and he's drawing the hand, extended arm and the flexed arm. So he's actually creating a medical illustration inside a painting about something that is not a medical illustration. Even if it's anatomically correct, and this is one of the successors of Nicholas Stolp, Frederik Kruijs in the Netherlands, who is doing the dissection of a stillborn baby. It's probably the first representation in art that I know of the placenta, very accurate with the umbilical arteries, 2 arteries, 1 vein, the urachus, so very precise, and yet this is not really a medical illustration. Now, some other examples of what I would call accidental medical illustrators. Paintings that were never meant to be instructional, but in this day and age may in fact be considered as such. For example, Sustermans was the private painter of the Medici family, and he painted 2 portraits of the young Ferdinando. See here, 7 and 9 days after Ferdinando developed a fever and a rash. You can see the rash in the beginning is kind of red, and then it becomes those papules, those pustules. And essentially, this is, anybody knows? This is smallpox, exactly. And we don't have smallpox anymore. We're not supposed to anyway. Maybe in some lab there is, we heard about monkeypox. But why this is important is that this is a disease that we don't know anymore. And maybe this is a one way to illustrate something that no longer exists and that probably no physician will ever see, unless of course there is some outbreak. I'm happy to report, by the way, that Ferdinando did fine and it left no scars, as you see from the portrait from a decade or 2 later. Some artists. That's no.
Go ahead, Steve. You do it.
There we go.
One more thing. How about this?
Yeah, much better.
There we go.
Thank
So,
you.
if you touch enough buttons, eventually. Some artists themselves had some mythology. This is a lesser known expressionist from the Netherlands from last century. Dick Katelyn, as you can see, didn't live very long because he was born with a congenital disease that some of you may recognize. You can see his clubbed fingers, the acrocyanosis, the blue fingernails, and he had a cyanotic heart disease. Some people have said it was a tetralogy fellow. It was probably transposition of the great vessels, but we're not completely sure. So another documentation of a medical problem, even though that's not strictly speaking a medical illustration. So what is the real purpose and essence of medical illustration? Why do we need medical illustration? We need it to explain to patients and families. We need it to teach, which of course is the essence of the Frank Natter School of Medicine. We need it to brag. I'm bragging. To present, as you see, all my co-speakers will be doing the same thing if you present at conferences or to colleagues. So essentially, in one word, to communicate. Just a little bit of history of where we were and where we are now. 1543, sort of kind of watershed year, certainly for medical illustration. This is when Vesalius published his Human Corporis Fabrica. Maybe not the first, but certainly the most famous atlas of human anatomy at that time and still centuries later. Mostly famous because it was incredibly illustrated with beautiful woodcuts, which again shows the importance of illustration. It also, I think, coincides with the birth of modern medicine. And now for the next 2 to 3 centuries, it was really the age of anatomical discovery. Nothing had been described in detail before, and so a succession of professors and physicians and anatomists in all countries in Europe mostly described structures that they then named after themselves. And of course, they needed medical illustrators to reproduce those examples. Here, an example of the Hunter brothers, who like William Hunter and Jan van Namesake, who was then a very famous illustrator already. And then the 20th century saw the birth of anesthesia, asepsis, so many other concepts that we now take for granted. And all of a sudden, it became surgical. I know I'm biased, I'm a surgeon myself, but certainly there was a kind of a change at that time. And medical illustration became less static, less about anatomy and more about dynamic. You needed narratives, you needed to show the process of an operation. And so medical illustration took a huge turn towards surgical illustration. And then, of course, as we progressed through the last century, we went into the microscopic, the ultra microscopic, the molecular, and medical illustration now became something that was needed because you couldn't see those things with the naked eye. So you needed somebody to represent it, all the way down to those, this is David Goodsell, a remarkable scientist and illustrator who has published a number of what he called beautiful but deadly viruses. This is, of course, the SARS virus for COVID-19, and down to the molecular ways to describe micromolecules. And now it continues because we have big data, we have animations, 3D, 4D, and so on. And so medical illustration is still alive and well. Why is it alive and well? If you think back a century or two ago, illustrations were much better than photography, of course. You see here two pictures of the same procedure in endoscopy. And on the right-hand side, it's a photograph. It's grainy, black and white, and it proves that they were there. And that's pretty much all you can see. On the left-hand side is the illustration of a Max Bradel, and you can see how this was necessary because it was the only way to represent medical topics in detail. But now we have photography. We have anybody with an iPhone can make incredible photographs, videography. This is 2023. Why do we still need medical illustration? Well, we heard a little bit about cognitive load, and when you think about cognitive load, you have the intrinsic, the extraneous, and the germane. The intrinsic is the Krebs cycle is something that I will never understand. It's way too complicated, but there's nothing I can do about it. That's what it is. So the intrinsic load is what the problem is. The germane cognitive load is what you really need to understand a concept. And then you have the extraneous, the superfluous things that are just distracting us. And this is what you see in this photograph. This is a photograph of a hysterectomy, removing the uterus. And yeah, it's a little bloody, and you see there are labels, fortunately, but it's a little difficult to read. This is a carbon dust illustration of Max Bradel of the same operation. And you see, it looks like real life, black and white, of course, but it's cleaned up. So you don't have areas that are distracting. You see it goes down straight to the point. And so that illustration is much clearer, I think, than the photograph. I would argue that this pen drawing, also by Max Bradel, is even better, because if you are trying to do, or you need to do a hysterectomy, you can probably learn even more from that drawing than from something that's very realistic. In fact, it doesn't even have to be that sophisticated or elaborate, as long as you can explain it correctly. So can we use those principles in our daily practice as physicians or physicians to be? And as has been said before, I believe that all doctors draw. Some draw better than others, there's no question about that. But I think we can all learn to draw better and to perfect our and so this is where ArtMed, the next generation, again, apologies to Star Trek. What I want to talk about is what we certainly at Brown have done in terms of trying to train the next generation of physicians and healthcare professionals in general. So for the last decade or so, we've been giving courses in workshops in medical illustration to first and second year medical students, to undergrad students, as you heard, students at RISD, the Rhode Island School of Design, and even to residents and faculty. And when you think about medical illustration, and the illustrator, of course, Frank Natter, the medical illustrator needs to understand the concept, for example, of an operation or a cascade or whatever needs to be represented in order to be able to illustrate it. But I would venture that if you understand how the illustrator got to that point, it helps you understand the concept itself. So there is this two-way street where understanding how medical illustration was done can also help us. And so the exercise of trying to make an illustration can teach us how to understand it better. And so the idea is to not to make everybody into a Frank Natter, but at least try to see things from his point of view. And so the course that we teach, and that started 2 days ago, starts with very simple things, drawing 101, light and shadows and the gray areas. For example, we understand that by convention light comes from the top as the sun of the lights, but typically top left, and so that means that any surface away from that would be in the dark, as you can see here. And this is simply illustrated with a cube, but it also goes with more complex figures. And I like this one because Vermeer, pretty much every single one of the Vermeer paintings represents 1 to 2 to 3 characters, and typically with a single light source, as you can see the window on the left. And it's great if you want to learn about this to just observe how he did that. In fact, if you look at the girl with the pearl earring, even though there is no window, you know exactly what the window is. You see the illumination from the top left. So it's a great exercise to try to see how this is done. Why is this important? Well, this is a circle. And depending on where you're going to put the gray areas and the shadows, you can make it into a ball, cue ball, or in something that is concave. And an immediate medical application is the difference between a normal red blood cell and a spherocyte. And so just learning how to apply shadows and light, know where the light comes from, allows you to make your drawing, your illustration clearer without going into very elaborate art. You can make it into elaborate art, but when you start to analyze it, it's all pretty much the same principles. What we also do in classes, instead of having something like that that's grayscale, teach students how to use texturing, very simple lines, so that you can give more volume to your drawing and to make it clearer, not only more beautiful, but also clearer. Now, we all know that a picture is worth 1,000 words. I would argue that a good picture is worth 1,000 bad ones. And what I mean by that is, this is the next step, not only illustrating what you see, but thinking about a process. Again, I'm biased because I'm a surgeon, but it applies to a lot of other specialties as well. This is a just single illustration of a laparoscopic appendectomy, removal of the appendix. This is 8 figures of an appendectomy, 1 through 8. This is how you do it. And that's how you do it. It looks like a storyboard. It's redundant and repetitive. You see a lot of cecum and a lot of appendix, and you have step by step by step. And one of the beauties about mental illustration is that you can telescope time and space, but especially time. And this is what I like to refer to as the IKEA model. Why IKEA? Because very few companies have been able to master this. Paper is expensive, ink is expensive. They export to so many different countries that the less words, the better, or the fewer words, the better. And so they have become masters in creating just the right number of illustrations, just the right points of view. And I think you can apply that to medicine as well. You don't have to give it a Swedish sounding name, but it's pretty much the same principle. And so to go back to the appendectomy, you can illustrate this same operation in only 2 illustrations. And I want to point out to the one on the right, number 2, you notice that the scissors are halfway cutting through the appendix, while the top, while the top loop there, the suture is not cinched down yet. No surgeon worth his salt would ever do that. You first you ligate, then you tie off. But the whole point is to telescope time, and you can use the viewer as an accomplice and to work with them, because a viewer will understand that you're supposed to do this sequential way, not at the same time. And so that's a way to think, to analyze, and to create your illustration, which in my mind also helps you be a better physician or surgeon. You don't have to do everything in drawings and illustrations. You can use arrows, you can use symbols. Clearly, this type of kindergarten scissors is not what we use in the operating room, but it's the principles, the idea. You want the symbol. Clearly, no surgeon would ever cut through this vessel by using the blade without a handle, because that's dangerous. But you know what it is. Most surgeons, most people would recognize an 11 blade here, and you don't need the handle, which would essentially cover up other parts of the drawing. It's understood that you need a handle. If you want to explain, you want to show what a symbol of a doctor, that's easy enough to do. Everybody recognizes the stethoscope. If you want to explain something about fatty diet, well, you can use pizza. People will understand. So the idea is to take shortcuts and to use those symbols. And in fact, so we not only become illustrators, we become communicators. We can use archetypes and symbols in other ways as well. On the top, you see the lungs. Below that, it's a stomach. Top right is, of course, a heart, and the bottom right is a kidney. And you can try to spend a lot of time drawing these organs very faithfully, or you can just use the symbols. Everybody will recognize that, and you will save some time, and you can be much more effective in communication. And Christoph Niemann, I don't know if you know him, he's a phenomenal illustrator who's done a lot of work published in the New Yorker and other places, and he facetiously or semi-facetiously uses the abstract medium. So if you draw or paint a bloody heart that is violently pierced by an arrow, that does not evoke love. On the other hand, if you draw a red square with a black line, I have no idea what that means. So the sweet spot is right in the middle where it's just clear enough that people understand. So I have a couple of exercises here, at least a couple of tests. This one, for example, this is a fantastic ad campaign by Lego from about a decade and a half ago. Everybody recognizes who that is. You can shout it out if you know it. It's The Simpsons, of course. How about this? It's a little delay here. Yeah, I gave it away. What about this? South Park, exactly. How about this? How about this one?
Mistake, Final Billy.
Yes. And so in an American audience, there's always one person who knows it. And this is probably not very well known in the US. It's incredibly popular in Europe. How about this one? I hope that everybody recognizes the Portuguese national team. The little thing here is that you have to know your audience. And so if you want participation, if you want the audience to understand what you're trying to do, you have to know what they know and what they don't know. And so that's another way to try to interact with your audience. So preparing a sketch, learning to simplify, as I just showed you, I think teaches one to draw more clearly, but also to think more clearly. And the reason why I have Einstein there is because he may or may not have said that if you can't explain some complex idea in simple words, you probably don't understand it. I don't know if he said that. I'm not 100% sure that that's true, but still, it's a great exercise. Try to force yourself to simplify things. And you'll hear from Karen Rucker a little later on about visual abstraction. I think that's about that as well, trying to simplify. So Ken, we're going to spend a few minutes now talking about some real life advantage of the drawing. So can we use this in our day-to-day life? Like I said, I'm a surgeon, and is a picture always worth 1,000 words? So let's say you have gallstones, or you have a patient with gallstones. This is a very simplified illustration of the various bilirubin pathways and how you get gallstones. Is it clear? Well, it's colorful. But I think that not every picture is better than text. And so here, this is not so much medical illustration, but medical or visual communication. First of all, find out who your audience is. So let's say you have medical students or residents, and you want to talk about gallstones versus patients. So this would be perfect for, I think, medical students. You have gallstones, and where do they come from? They can be cholesterol stones, or they can be pigment stones. If they are pigment stones, typically they come from an elevation in bilirubin, which very often would be because of increased hemolysis, and this could be because of thalassemia, sickle cell disease, or spherocytosis. Of course, it's simplified, there may be more, but that would be pretty much what you guys need to know to take your tests. But what if you're a patient? You probably don't really care about all those things. Let's say that you start the other way around, you know, because your dad had a splenectomy and your grandfather had a splenectomy, that you were born with spherocytosis. So you know you have spherocytosis, you go to the doctor and you want to know why you have gallstones. Well, because of spherocytosis, you had an increased hemolysis, which led to an increased bilirubin and led to pigment stones, and that's why you have gallstones. So depending on your audience, you can construct it and analyze it, construct it differently, and I think that's the one way where we use that illustration. Now, we can explain what causes gallstones, but what do we do about it? How do we explain that? And most importantly, if I'm taking out your gallbladder, how do you know that you'll be able to live without a gallbladder? Well, you can use very simple illustrations, just a triangle for the liver, and you can see that the gallstone is really kind of a sidetrack to the bile ducts. that if you eat pizza or fatty food, so here's a pizza again, you see that the gallbladder squeezes bile through the bile ducts into the intestines to help you digest. But if you remove the gallbladder, as you see in the illustration on the right, the bile ducts still remain intact, and so you're still able to digest food. Very simple graphic. Note that it does not have to be a very elaborate painting, a 3D color painting of gallbladder. So, in conclusion, medical illustration is not just about art, but it's about visual communication. And I believe that pretty much all doctors draw, that we're all visual communications. Just like we can learn about bedside manners, I think we can all learn the language of visual communication that will improve our skills. And I think will make us better, more compassionate physicians, communicators, healthcare providers. And it's not necessarily about art. There's a book by Mark Rode about the sketchnote handbook, and he makes the point that there's not much difference between a good drawing of a dog and a bad drawing of a dog. Either way, it's similar. Thank you. Any questions? If not, yes.
This is amazing presentation, and I think for all of us, it just gives such a good opportunity to look into this visual communication. My question is about artificial intelligence, how that will change our reviews and how that can be helpful.
That's a great question. The question was, what is artificial intelligence? What will it do to the field of medical illustration? Or I would say this is pretty much a question to any lecture about any topic anywhere these days. Ian and Anika will attest to the fact that this was a major topic at the most recent meeting of the Association of Medical Illustrators. I think I'm not an expert about that. There are two things I want to say. Number one, if you want to create, just like I showed you that you can lift off scissors and arrows and pictograms from the internet, if you want to use the computer to make illustrations better, why not? I think I still find it's fair play, and I'm also happy to share my illustrations online so for other people to use it. I think you need attribution. So I don't think that AI per se is something brand new. It's still a continuation of what we've already had. The bigger issue is copyrights and who owns the copyrights and what is it art or is it just an illustration? And a lot of people would say that something generated by a computer cannot be called art. But that's, if you like it, if it's beautiful, it's fine. But I don't think it can be called art. Who owns the copyright is a bigger problem because the way the AI is generated, at least for illustrations, it takes this huge bank of data from the web, and that includes a lot of original work from a lot of artists, and they absolutely need to be protected. How it's going to happen, I have no idea, but it's still a big debate these days. Yes.
Question about your one-on-one class. Curious, does your approach to the students who appears to have very little artistic talent, does your approach anyway, how to guide to change anyway? How do you help move that student where you would like them to be?
That's a great question. So essentially the question is the one-on-one drawing classes, how do you handle different levels of artistic skills? And it's certainly true, and we talked about this on Monday with the students. We have some students who come from art school, go down to school of design, and others who don't know how to draw. I would argue that all the students who come to the class are interested in it. At least they are adjacent. And my answer is, and I've seen this over the years, you're not competing with others, you're competing with yourself. So if you come in and you have no idea how to draw a straight line, and at the end of the class or the course, you've been able to accomplish some of it, that's a huge accomplishment. If you come in with a lot of skills, and the Rhode Island School of Design students are incredible, there's something else you can learn. In terms of communication, in terms of medicine, and so it's more you're competing with yourself. You try to improve yourself no matter what level you stand. That sounds very idealistic, but I think that's it. Another question?
Thank you.
us. That was the perfect setting of the stage for today. So I wouldn't be truthful if I didn't admit that I'm particularly thrilled to introduce Dr. Katelyn Norman. She's a graduate of the class of 2017. QU's inaugural class, or QU Netter's inaugural class, excuse me. She's now a faculty member at the Yale Waterbury Internal Medicine Residency Program and assistant professor of internal medicine at QU Netter. I say that she's one of my students, so I'm so honored by that. She received her Bachelor's of Fine Art from New York University, where she studied studio art and painting, and then went on to medical school at QU Netter, graduating with high distinction in medical humanities. She completed residency training at the Yale Waterbury Internal Medicine Residency Program, where she subsequently served as chief resident and now core faculty, where she directs the new medical humanities curriculum. Her professional interests include clinical ethics, and she co-chairs the Waterbury Hospital Ethics Committee, as well as medical illustration and fine art. And her presentation is Flesh, Bone, and Breath.
I can't thank you enough for that introduction and for having me. Really exciting to be back. So here we go. All right, so flesh, bone, and graphite. So I'll start a little bit with the agenda. So I'm going to spend a little bit of time giving you guys an introduction to forensic art, specifically facial reconstruction, or probably more aptly named facial approximation. I should begin by saying that I was an artist a long time before I was a doctor. And in preparing this talk, my perspective on this project, which began as a capstone project here at Natter, has changed. I've included some of my paintings, which have been done at various points in time in chronological order throughout. I'm going to use this sort of as a framework to discuss what it means to be a physician artist, at least to me. So forensic facial reconstruction from skeletal remains. There are three really big steps that go into this. So one is the actual creation of the reconstruction or the approximated face, typically from remains that you don't have a lot of information for. The second step is it needs to be publicized and made available, whether it's on a database or through a media campaign, such that someone identifies the face, thinks they recognize someone. And then the third major step, and it's not an identification until this happens, is a confirmatory testing. So usually DNA testing, sometimes dental records. I know I talk's a little dark. So this all begins with an analysis of the skull. Typically, a forensic anthropologist starts by taking some measurements and looking at different bony landmarks, and they tell you what they can from the available bone. Usually you get an approximated age within a 10-year time span, biological sex, and then race and ethnicity. You can imagine this gets trickier as the bone is worn away, the longer it's been, animals get to it, and it's a little easier if you have hair, clothing, pieces of jewelry, dental implants, things like that. So I'm going to stop here for a second and talk about something that came to mind as I was preparing for this talk, which is the idea of the deceased as a patient. Facial reconstruction is performed really in the service of the deceased, which is something unique to this type of medical illustration. It wasn't until now that I truly appreciated how much facial reconstruction mimics what's so wonderful about bedside medicine. The intimacy of the relationship, the uniqueness of the case, the pursuit of excellence in practice and how it's often undermined by absent or imperfect means of resolution. So I'll just let you stew on that while I go. So we begin with craniometrics and landmarks. So on the skull, there are a number of really important points, and they've been defined in the literature going back to when this was first pioneered in the 1800s. And each of these points are used for both data collection for the practice of medical illustration, but also for the building of the approximation. So you'll notice on this skull, I have these little points that have these abbreviations, for example, like the mental point, which is the bottom of the jaw. From these points is how data is collected about tissue thickness. So different researchers throughout history have done studies on different populations collecting data as to how deep the soft tissue is. At each of these points created data sets, which can then be used by a forensic artist. These data points, these tissue depths, are combined with what we know about muscle insertions and ligaments and so forth in skull morphology, which is where you can look and see where the insertion sites of the main muscles are, where the eye sits, for example, where the lacrimal duct rests on the top of the zygomatic arch. And then finally, facial relationships. So a lot of these are defined by art literature, and you may have heard of Da Vinci's Golden Mean and other relationships whereby we create an aesthetically pleasing face. So for example, the ear is generally roughly as tall as the nose is. So feature surface and details. So some features are easier to predict than others, I should say. The eye, the nose, and the jaw are typically the most accurate features in a forensic facial reconstruction, and other features like the mouth and the ears take a little bit more guesswork. The surface details like skin tone, effects of aging on the skin texture, hair color, eye color, and so forth are all really hard to anticipate and often become problematic when you're trying to achieve an identification. I think discussing the intent is important here because as an artist, I found when I was working on this initially, I was very preoccupied with accuracy and perfection. I wanted my reconstruction to look photographically like the person that it was supposed to be. But that really isn't the intent. The intent is not for me to make a beautiful portrait. The intent is to spur a recognition that leads to an identification. And the way someone recognizes a reconstruction is different than you might imagine. And I'll go into that a little bit. So here is an example of a facial reconstruction that I did as part of when I was here at Natter. It started with an MRI scan of a volunteer where the digital measurements were taken. I printed it, the anterior and lateral views, and this is called Karen Taylor pioneered this method. Then on vellum, you plot the points that I had mentioned earlier. You sketch in where the musculature goes, and you sketch in the thickness for a population of people who meet the same age and racial origins. Finally, you finish the sketch and you adjust the features and you come up with an approximated image. And typically they look very sketchy because you're trying to give people an impression, but you don't want to overly commit to things that you don't know. So there's problems with forensic facial reconstruction. So the size is one big problem. So technique and method validation studies almost exclusively rely on a small number of reconstructions by a single artist. The data that's used to complete these reconstructions is infrequently updated, and there's no formally accepted standard for which practitioners are held. And this is my favorite thing to talk about, which is the audience. Data suggests that the way a familiar face is recognized is neurologically different than the way a learned face or a celebrity face is recognized. So you can imagine if I'm trying to validate the accuracy of my reconstructions, how might you arrange that study? You might show a reconstruction, give my participants different photographs, try to pick which person it looks the most like, or show them a picture of a person and then have them pick a reconstruction. But the problem is, unless you are a family member looking for a lost loved one, you don't remember that learned face the same way someone else does. In fact, there's some interesting research that shows that family members and close friends are actually worse at approximating an image of a loved one than someone who's just looked at a photograph a few minutes earlier. So it's I mean, this is why I love internal medicine. It's the gray area of everything that's so exciting. So this is the reconstruction compared to my mentor when I was here at Natter, Dr. Richard Gonzalez. You know, it's pretty close. It's not perfect. And I think I fussed over that quite a bit when I did this project initially. But going back to the intent, the idea is really to spur a recognition which leads to an identification, not to be perfect. Because when you become overly confident and you overcommit is where you make mistakes. And I think that's probably true in medicine as well. So I do have some final thoughts and a couple more points to make. So one is the other two areas of forensic art that I didn't touch on are composite drawing, which you might imagine is the witness to a crime sits down with a sketch artist and I creates a likeness to help aid in identification and also age progression for missing and exploited children. But I think what I'm trying to get across is that a reconstruction is not so much a portrait as it is a procedure. And a procedure which demands technical skill, humility, and sensitivity, which is a lot like the practice of medicine. Forensic facial approximation is really a beautiful intersection of not just art and medicine, but the direct application of art to the care of a patient. And in closing, my final thought, that art and medicine are alike, and that the mastery of each requires endless study and deep commitment to humanism. There's some sources for you. Any questions? Yes.
Are all of the illustrations that you had in your presentation yours?
Yes.
Okay, Katie, I just want to say, welcome back as a member of the pioneering class. And my question has our students in mind, thinking about the fact that you came here as an artist. Many of our students, as we've seen today, are artists or have other passions and interests and hobbies. How did you manage as a student to carry that with you throughout your 4 years? And what are some lessons that you learned that you might be able to impart to our students?
I think there's a lot in common with practicing medicine and practicing art. I think both very much become your identity in a way. I think when you're a little kid and you're good at drawing and your parents start putting your pictures on the refrigerator and you begin to identify as an artist, it becomes very core to how you think of yourself. And I think that's also true for being a physician, where you think of yourself as an artist or a physician first and sometimes other things later. And so it's hard for me to think of anything I could do that would keep me from practicing art. Now, there are certainly times where I've done less art and times when I've done more art, but you have to, you'll make the time. You'll make the time, I guess, if that's an answer to that question.
Thank you.
Yes.
My name is Pia Dobe, and I want to share a reflection more than a question. This has come full circle for me. I trained at the University of Ghana, and I'm currently Dr. Norman's colleague at Waterbury Hospital. And we read Frank Netter's book of anatomy all the way in Ghana, West Africa. And it's just very humbling for this to come full circle, to see this school 10 years in the making, to see the artwork displayed, medical illustration is displayed here, and Frank Netter's daughter speak at Waterbury Hospital, Grand Rounds, and to see the products of the pioneering class of Frank Natter School of Medicine become a colleague with me, and have medical illustration of this degree. And Dr. Norman continues his scientific inquiry at the bedside. And to see, Katie, what you have shown now, the humanity tied to the work of art. Among the students here who train with us at Waterbury, to see this and see that we don't just do these things for fame, for scientific inquiry, but to link it to making the lives of our fellow human beings better. That's what's striking about what we're doing here today. And I thank you for the humility you've shown in saying that you're not just trying to reconstruct for the likeness of somebody to make the art nice. That's not the goal of it, but for recognition. And the humility you've shown and the passion for this deceased person to also be our patient. That's what I'm taking away from what you said. Thank you so much, all of you.
Any other questions? But he wanted to follow Dr. Johnny's beautiful, beautiful words. Our next speaker is Dr. Michael Natter, an assistant clinical professor of medicine and clinical endocrinologist. At NYU Grossman School of Medicine and NYU Langone Health in New York City. He completed medical school at Jefferson Medical College in 2017 and went on to do his internal medicine residency and endocrinology fellowship at NYU Bellevue in New York City. He was awarded Fellow of the Year, both years of his fellowship, as well as Teaching Fellow of the Year in 2020. His work has been published in media outlets such as Diabetes Care, BuzzFeed, Medscape, and Philadelphia Inquirer, among others. His background in the fine arts in his childhood, diagnosis of type 1 diabetes, has informed his practice of medicine, which he believes should stem from a place of empathy and humanism, which we just heard. Dr. Natter's presentation today is titled Learning Outside the Lines, Why Medicine Needs Art.
Thank you so much. It's very hard to follow what we just had heard before, but I will do my best. I first want to begin by saying that I'm Mike Natter. Unfortunately, that's an A, not an I also want to say a special thank you to Dr. Lux who invited me to be here and all of you for having me. I really appreciate this beautiful campus and a beautiful day. So before we begin, a couple of disclosures. I've done some work for GoodRx and some work for Replica Health as a medical consultant as well as an illustrator. And to begin, it's a particularly unique honor for me to be here today. Dr. Frank Natter has been a hero of mine really since childhood. I, like Natter, grew up in New York City. I took figure drawing class at the Art Students League. I, at the encouragement of my family, redirected my art school into medical school. And I found myself training at the famous Bellevue Hospital. Natter's Atlas of Human Anatomy is a staple in every medical student's hand. But to me, it had a little bit more meaning. It meant a tangible, beautiful proof and evidence that I could be a doctor and an artist. And it really helped me recognize that those two identities were very much kind of tethered in one and the same. And I can say confidently that Dr. Natter has given me a big reason for why I'm able to kind of achieve the goal that I've been able to achieve today. Speaking of goals, some goals for the talk. I am hoping that I can demonstrate the role of art as a powerful communication tool. I'd like to show the different applications that art can have in medical education and training, illustrate using actual examples of how art helped me personally through my medical training. And I hope to encourage all of you, if you don't already, to utilize art in your everyday practice. So I'm an endocrinologist in New York City. This is a picture of me as a fellow at Bellevue Hospital, and you'll also pick up there's an insulin pump in addition to the massive amounts of pages on my belt there. But I also, and honestly, more comfortably identify as an artist. So why am I here? I'm going to make the case for why I believe medicine needs art. I come from a very different background. I went to art school. I kind of had what's called a non-traditional route to medical school. So I feel as though I see medicine through a very different lens. And at times that lens has felt like an outsider, but now more and more I'm realizing that it's really one and the same. So before we begin, we need to first operationally define art. what is art? What do you all think about when you think about art? I'm gonna guess no one's gonna say a word. You takers?
Beauty.
Beauty, I love it.
Creative.
Yes, creative.
Expression.
Expression, great.
Imagination.
Imagination, beautiful, great. Right on the chat. So I believe that we're born with this unique ability to understand visual imagery. It's a very kind of natural experience for us. We don't need formal training to really be drawn to images and to use images. We all draw as children. And so for that reason, very similar to Dr. Lux, I believe medicine, art is very much about communication. And this communication can take very many different forms. So classically, art is going to take the form of these beautiful paintings we see in the museums like Jackson Pollock's. We can actually feel in the communication of the emotion and the frenetic energy that Jackson is using as he's throwing the paint on the broad canvas beneath him. But art is also trying to sell us things. Can anyone tell me what this might be an ad for? I think I heard it. McDonald's?
McDonald's Wi-Fi, someone said.
There you go. Whoever said it nailed it, right? So, but how did you know that, right? So the image before had no logo, it had no word, it had nothing. All it had were two very distinctive colors, and then French fries in a very peculiar pattern, right? But we have a shared social vocabulary. Those colors are very specific to a certain burger house. We all inherently know what those colors mean. We also happen to know what that shape means, and so we make that connection as the audience, and we're being kind of sold to in vision, which again is a communication of sorts. As Dr. Lux brought up Christoph Niemann, I am also a big fan, and the idea of using iconography and using simpler form to communicate is also very key. But remember what Dr. Lux said, if we get too simplistic, we're going to lose some of the audience. And conversely, if we get too rendered and too overly realistic, it's a little bit not as clever in that the audience member does not need to make a cognitive leap to meet you where you want them to meet you. So I would argue finding that sweet spot in the middle is actually the best, almost ideal place for the designer or the artist to go. Again, depending on the piece. I also like the idea of using everyday objects and challenging myself to see them from a different perspective. So this was me as an MS2 cooking some dinner, and I happened to be in my pulmonary block, so this is what I saw. And then studying for my renal block. So what does all this have to do with medicine? I believe everything. I think what makes good medicine is the same thing as what makes good art, and that's effective communication. We communicate regularly in medicine. For example, very obviously, when we're doing a code or rapid response on the floor, we need to communicate effectively and efficiently with our colleagues. We need to be using closed loop communication. We need to make quick, fast, serious decisions. But what about when that communication is less obvious? It is said that from the history alone, that one can correctly diagnose the patient 83% of the time. 83%. That means no imaging, labs, physical exam. That's just listening and talking to your patient, hopefully more listening. But I would argue that unless you're communicating effectively, and unless you're using that kind of rapport and building that comfortable environment that the patient will give you that information you need, you'll be able to listen and hear what they're having to say to make that correct diagnosis. So that brings us back to my journey in medical school. So remember, I'm this timid art kid coming into medical school, don't feel like I belong. And I found myself doodling and writing little kind of visual notes on the margins of all my little notes. But when the test would roll around, all I could remember were my doodles. So I thought, let's go for it. I traded out all my notebooks for sketchbooks, and I started to really draw everything I could when I was in medical school. And I found that my art really falls into one of two buckets. There's this didactic bucket that I was teaching myself medicine, and now as an attending teaching my patients and my medical students. But there's also this cathartic bucket, because art has so much more that I can offer than just the teaching component. So let's dump out some of that didactic bucket. Hopefully I'm not running too short on time. We're doing okay. We're gonna make it work. It's gonna be okay. So before I could really tackle the intricacies of the nephron and kidney, as many of you can attest, it's a little complicated. So I thought of the kidney as a box. Now it's a complex box on the left. I hope there's no nephrologist on the bending. But it's a box nonetheless, with some afferent portals here, blood flowing through there, you get a little bit of urine coming out. But this was the oversimplified groundwork for me to really understand what I was about to learn. Because as we know, what's going on inside this box is crazy. There's a lot of electrons and sodium and white blood. But understanding this groundwork, getting that basic idea in my head and simplifying it, allowed me to better understand this. So from then on, I realized I can kind of use this little humor and these little cute cartoons to help me really understand what's happening. And so, for example, now as an attending, I still think of aldosterone as this little dude picking up sodiums and dumping potassiums. And he's turned on in states when our body needs more volume, more blood pressure. We always, always, always have to produce things like the kidneys, right? Never let the kidneys go without perfusion. Big no-no. Dr. Lux would be not happy with this. So I continued in this way. I started to use my own visual language to teach myself medicine. I was breaking down these very complex, cardiac physiology into things that I could understand or even a child could understand. When I was in MS1, MS2, I'd throw around terms like afterload and preload, had no clue what that meant, none. Until I sat down and thought about it and drew this image. And now I really, fully, truly understand it. In the same way, I thought about afterload as the left ventricle of a beefy bodybuilder. And the more afterload you had to push against would be like weights and bench press. It made a lot of sense to me, and it really helped me encode, understand, and utilize medical topics. Simplicity is also important when we're talking about illustration and medicine learning. Diabetic ketoacidosis, DKA, very complicated medical physiology. It's very abstract as well when you think about it. But if we simplify macroscopic neutrality, the swapping lemons for bananas in the state of acidosis, it actually can become a little bit more approachable. And I think it's actually very helpful when you're first explaining it to their patients or medical student. Humor also helps. It makes the concepts more sticky. So when I was in MS3 rotating through my psychiatry rotation, I first learned that the bulk of our serotonin receptors actually reside in our gut, which was news to me, and not in our brain or CNS. I made this little comic, and this little platelet on the side too, he's got some too. What about teaching our patients? When I was a third-year resident in New York City, COVID happened. Could not have imagined such a terrible thing would happen. And I realized that a lot of my patients barely had a ninth grade biology education. So when all of this information, mis and disinformation were out there and the COVID vaccine came out, I wanted to ask myself, how can I better position my patients to really understand this? How can I teach? And I wanted to explain it using illustration. So I think of the COVID vaccine as a series of instructions. And there are instructions to make this guy here, obviously, the spike protein. And once injected, the cells read these instructions, and what do? They make a spike protein. The spike protein floating around in the body, and here we have our immune army with soldiers and little spears, and they're rolling around, they're patrolling, and what do they see? Oh my God, what is this? So they call their buddies over, and they attack. In attacking, they recognize the value that some of these spears have, and they say, we should probably hold on to some of these guys and make more of them, and in doing so, if we do come into contact with the virus in nature, we're better armed to take care of it. Now, clearly an oversimplification. But to go through immunology and really break down these difficult topics to our patients, sometimes simplifying it in this way really gets the message across, and at least gives them a basis to understand. I do this every day in my clinic. This is an example literally from yesterday when I was in clinic before I came on the train out here. Every day I explain to my patients using illustration. I have a belief that every patient deserves and needs to know their pathophysiology and understand it. They spend 15 minutes with us every few months, maximum. How can we expect someone with a chronic condition to take better care of themselves if they don't understand their condition? Unfortunately, I think it's a failure on us as physicians if we don't educate appropriately. Now, I took care of patients at Bellevue. I took care of patients who don't speak English, who don't have the same educational and cultural backgrounds as myself. That is not an excuse for them to not understand what's going on, and it's a failure on us to do so. Drawing breaks all those barriers down. It flattens that out. In addition to drawing, you're also creating a rapport with your patient. The few minutes you take to draw, and I agree with Dr. Lux, we're all artists. The process we're taking is so much more important than the product, because you're taking the time to explain it. Even if it ends up as scribbles, your patients will want to take that home, I promise. So while I'm at school, I had this kind of realization. Here I am drawing all this stuff, and I'm thinking to myself, I have to absorb and drink from this virus, this volume of information that flows at us so fast. How can I change or adapt the way that I'm learning, and I think everyone should, in order to better encode, retain, and understand this information? So a lot of my colleagues in medical school, they'd sit in lecture, they'd get that auditory and visual information from the lecture, but they were bypassing this key part, which is making the material their own. I think that piece is so necessary. Additionally, I find that when I think of learning and memory, there's a very specific brain structure that comes to mind. Are there any neuro nerds in here? What brain structure do you think about learning and memory? Hippocampus, someone's listening? I agree. Look how small that thing is. It's tiny. It's a tiny structure. The hippocampus is so small. It's kind of like, I live in New York City. It's like living in New York City in Manhattan. I spend way too much money on rent to live in a tiny little walk-up with no, it's a studio apartment. Why am I doing that? It's silly. What if I move to the outer boroughs? What if I move to the Bronx, Brooklyn, Queens? I get so much more real estate, much cheaper rent. Those outer boroughs are visual spatial pathways. They're untapped resources that I really believe we should start using. Now the cathartic bucket, we have some time for the cathartic bucket. We're gonna dump the cathartic bucket. So the cathartic bucket is a little different. So we hopefully, I hope I've convinced you all that there's clear didactic, merit to art and medicine. But what we do in medicine is so much more than taking tests. It's very emotionally, physically, and mentally exhausting. And residency for me was a particularly tough time. It felt like I was walking on a tightrope. I was so tired. I was seeing a lot of sad things. I was delivering bad news. I was dealing with COVID on top of all of it. And it was very difficult for me and heavy at times. So I found that my art was a really great release for me personally. There were times I felt like I was slipping, and in some cases even falling off the rope there. But again, it was art that helped me to regain my balance. Sometimes I'd be a little bit humorous, like poking fun of my firsts. So this was the first time I did a rectal exam in the emergency room, or sutured someone, or stapled someone as a med student. And I wanted to document that experience. Or perhaps rotating on the OB/GYN wards in med school and realizing, not quite the field for me. Or making fun of the culture of medicine that sometimes is a little bit old school of the see one, do one, teach one. And then addressing these transition points, which I think are particularly anxiety-provoking in medicine. Like when I went from MS4 to intern, and if I'm being very honest with you, it scared the hell out of me. But once in the throes of residency, I would sometimes poke fun at the absurdity that is expected of us sometimes. 28-hour shifts were hellacious. Q3 20-hour college shifts, it was horrible, but I could make fun of it. Other times I felt that some of what I wanted to talk about had nothing to do with joking. It didn't feel right to make fun of it. It made more sense for me to really document and touch a piece of what was really going on inside my heart and my mind at the time. So for example, I started making these graduate medicine pieces. This one was about my transition from medical student to intern, and this idea of climbing the ladder to get to the point where I had all these extra letters behind my name, I had a long white coat, and yet I still did not feel ready to jump and glide into that big plunge. This is an example of when I saw my first code in death as a medical student and wasn't able to comprehend it. I wasn't able to articulate the difficulty I was feeling. And there was times I'd come home from COVID shifts or from my 24-hour shifts or my night shifts, and I couldn't sleep because I was so distraught. And I couldn't talk about it, I couldn't think about it. I had to draw something. And in drawing something, I put those inarticulate feelings onto a piece of paper that I could close and leave and take off of my shoulders and get to sleep and do it again the next. There were times in the hospital, like in this particular scene where I was a senior medical resident for the first time, and I had to deliver bad news to a young patient about my age, which was very difficult for me. It didn't sit well with me. I couldn't, again, make sense of it. I needed some way to offload that from what I was sitting with. And art, again, helped me to do that. There are times in the hospital when you find these great single bathrooms, they're the good crying bathrooms. You can sleep away. There are times you need that. But again, art is such a catharsis. And again, the process you're taking and utilizing art in whichever way it is, it's going to be so beneficial for you, yourself, for your patients, for your med students, and for everyone. So some takeaway points. I'm hoping that I was able to communicate that art is a form of communication. Effective communication is key in medicine. Art can be used to hone our communication skills, learn, teach, retain, and retrieve medical facts, help cope with the emotional struggles of training, make us better doctors. Most importantly, I want to tell you that the process you're taking is more important than the product, and we don't have to be artists to benefit. So that's me. Yes.
If you do not follow the same question, I will just say that this is my reflection. I think the presentation proved that art is universal language. It doesn't matter what language we speak, but just seeing all these pictures, we can read a book of your life. And actually, this was so important for us, and you shared a lot. And I think that inspires us to use that as a sharing thing. Thank you so much.
Thank you so much. I appreciate that.
Did other students, when you were in medical school, say, hey, can you draw me something so I can study too?
That's a good question. The question was, did any of my colleagues in medical school ask me to draw for them? So it was funny. Initially, I was kind of timid and would hide in the library. I didn't want anyone to see me drawing. I thought it was like disrespectful to be taking something so serious and using illustration for it. And I started to post these things on social media more as a repository for myself, so I could study for step one selfishly. But my friends would come up to me after the test and say, you know, Natter, I had a couple of points with that comic you drew. And I realized it was actually helping a lot of my peers kind of indirectly. So it was really nice to see that. Thank you so much.
Dr. Natter. It is now my pleasure to introduce Vinal Francis, who goes by Vinny. And he is the biomedical illustrator of the Geisel School of Medicine at Dartmouth College. He has a BFA in medical illustration from the Cleveland Institute of Art and worked for over a decade at Lakewood Hospital and Medical Center as a digital media technician and manager. He went on to become the medical illustrator and visual design specialist for the Warren Alford Medical School at Brown University, where he also became involved in the medical comics workshop. In his current role as a biomedical illustrator for the Geisel School of Medicine, he provides graphics and illustrations for biomedical faculty and staff and consults on grant proposals. He continues to work in advancing medical illustration in academic settings and produces Soda Pop Hospital, a medical comic designed to address the most pressing issues experienced in healthcare. We'll be speaking today about medical comics' impact on health. Welcome.
Everyone, I'd like to thank you for inviting me. Thanks to the co-chair for inviting me. My name is Vinal Francis. You can call me Vinny. I'm a biomedical illustrator for the Geisel School of Medicine at Dartmouth College. I got my degree in medical illustration from the Cleveland Institute of Art, and I have loved comics and cartoons for as long as I can remember. First, before I start, Frank Netter's legacy and the influence it has cannot be overstated. For those of us who are medical professionals and do medical illustration, Netter's work is an instrumental part of our journey. So while graphic medicine is an intersection of medicine and art, just like medical illustration, I didn't become involved with comics until relatively recently, around the time of the pandemic. Today, I'll be speaking about how medical comics' unique properties make it not only an ideal teaching tool, but also a proponent of positive change in the healthcare field. Before we get into that, let's talk about what graphic medicine is and where it comes from. So, there have been many examples going back over a century of comics intersecting with ideas around medicine, science, and health. Most of what I've seen takes the form of satire, pointing out some flaw or injustice, or poking fun at the people involved, including physicians, patients, etc. Many brought up important social and political issues. You can still find humorous comics that take place in the healthcare setting, like the ones on top here. What separates that from what we're talking about here? I use the term medical comics and graphic medicine. The thing that I think separates them from the aforementioned comics is graphic medicine's perspective and intention. This is where the power of this art form lies. Instead of, or maybe in addition to, making the reader laugh, these comics make the reader think. They're showing you something for specific reasons. Instead of a punchline, there is what I call a point of poignancy. These comics are trying to improve healthcare, teach, and raise awareness. By using a medium like comics that is so versatile and dynamic, it is much easier to literally and figuratively put things into perspective for an audience, and can be done with text or image as well. Language of comics. Just as in the medical and healthcare fields, comics have their own lexicon and terminology. Gutters, panels, speech bubbles are a few of these terms. The term comic is flexible. It can refer to a single panel cartoon, a strip of 3 or 4 panels, or a whole page or even graphic novel. Simply put, comics are a sequential art. This is another way I relate medical comics to medical illustration. Surgical illustration, by its very nature, uses sequential imagery, showing the steps of an operation. The application of comics and its conventions for healthcare and medical settings and concepts was dubbed graphic medicine by Dr. Ian Williams in 2007. Graphic medicine has become an increasingly visible medium, with names like Annika Zerwick, Alice Jaggers, and Michael J. Green leading the way, to name a few. The Graphic Medicine Manifesto, pictured here, was published in 2007. Also pictured here is Understanding Comics. Scott McCloud is recommended reading for anyone interested in comics. So what follows is largely an account of my own introduction to the world of graphic medicine, projects which showed me the potential it has to impact our healthcare and medical spaces and create positive change. Speaking from personal experience, I have seen how comics have been used to show the perspective of a loved one of a patient in a rural ICU, and how they have been used in medical school setting to educate students. For myself as an artist, when I'm talking about perspective, I'm talking about it in the literal and figurative sense. As artists and as human beings, perspective is a very important part of gaining full understanding of a scene or situation. In healthcare settings, you will find a diverse population: physicians, patients, nurses, family members, administrators, students, technicians, as well as non-medical staff performing essential services such as security, environmental services, food and nutrition, and interpretation. These people come from all walks of life and demographics. Naturally, each of these distinct groups experiences the same thing in different ways. Even within each of these groups, down to the individual, the experiences vary greatly. We each have our own identity backgrounds, values, emotions, knowledge, and perspectives pertaining to each experience and interaction. Seeing the perspectives of these groups and individuals provides us with an opportunity to put ourselves in another's shoes and understand their point of view. If we are able to do that, it can ultimately lead to more positive interactions, greater empathy, and even improved medical outcomes. The term colorblind dismisses the fact that different people have different experiences, and this is doing the opposite of that. Instead of turning away from our differences under the pretense that it is beneficial for everyone involved, these works allow us to understand and embrace what the differences are. Once we understand that, we can act accordingly and act with empathy. The goal is not to be blind, but to see in the fullest spectrum of color. All of that is information, and the more information we have, the better. What I enjoy about this art form and genre is the efficiency in getting information across to the audience. We've already seen many examples of that. The combination of text and images has centuries of traditions, symbols, and cultural cues at its disposal. And as each new hieroglyphic or emoji is born, they are just as quickly assimilated into this medium. This combination can get to the heart of a matter very quickly and efficiently. I am privileged to be able to assist in teaching a medical commerce workshop at Brown with Dr. Lutz, and each year it deepens my passion for this art form. I'm able to help students achieve their common visions, and at the same time, I'm exposed to so many new ideas and thought-provoking problems to solve. If you'll allow me to speculate, one of the things I've started to believe since being involved with this is how it is beneficial for the students to have this as an outlet. Similar to what Mike and I were saying about catharsis. It not only enriches them artistically, it informs their medical education. Here, they have a chance to process things they may not have a chance to elsewhere. People all across the healthcare landscape can benefit from this too, sharing their experiences with their peers and community, and the ability to learn from these experiences and interactions. Showing other points of view builds empathy. Connecting over shared experiences creates something more like sympathy, or rather relatability. A comment from the point of view of a patient, med student, or specialist might really hit home if you share that experience. Dr. Glaubenflecken on social media makes short videos that really connect because of the shared experiences optometrists and other specialists can lack in hide. My first foray into graphic medicine came on the heels of a tragic event in the life of one of my closest friends from art school, who was a comics artist. In 2019, a loved one of his was struck by a pickup truck while riding her bicycle, suffered multiple injuries, and was in a coma. During this time, he spent months by her side in the ICU of a hospital serving a rural area, living in the Ronald McDonald house and in her room for hours beyond distant times. After relating to me the many things he saw and heard and felt during this time, I suggested that we use these experiences to create a comic. What came out of that was sort of pop hospital. Loved ones of patients experience medical situations in their own way. They can experience feelings of helplessness and the fear of not being well informed enough to make the right decisions. The systematic nature of its own mental. Based on the true events my friend experienced, we tried to encapsulate these perspectives into relatable snapshots that anyone could understand. Tried to make them as short as we could. We used cute monsters and animals to help take immediate separation from the reality of these heavy situations. All of these tools that are commonly with comic conventions help us get the message across. We had no definitive plans for it, but after being invited to co-teach the medical comics workshop, I wondered if we might expand on the series. At that time, I was wrapping up a graphic for a one-page article about bedside rounding for a journal submission. The clinicians I worked with, led by Dr. Rebecca Gardner, had sorted the different areas of note into 4 categories, and one of them was bedside language. They were talking about the adjustments that would have to be made when rounding in front of the patient rather than outside in the hallway. These adjustments are not necessarily intuitive and must be intentional. In regards to language, caregivers can avoid easily misconstrued words such as unremarkable or negative, medical jargon, or even words that just have a negative connotation. I realized this material would be a perfect fit for a comic strip. With her endorsement, we used the Soda Pop Hospital setting and created a second series, this one in color, based on their research on bedside rounding and the specific use of language in that setting. Since we were dealing with language, we were able to include humor for some of these comics. Dr. Gardner and I then collaborated on another comics project, this time for use in the curriculum. The idea was to model the type of behavior and manner of speaking the caregivers should give at the bedside, should use at the bedside, including physical cues like sitting eye level with the patient. Dr. Gardner wrote the script, and we began with researching, storyboarding, and character design. I consulted with her and created a diverse cast of attendings, residents, interns, and medical students. We laid out the bedside scenario and a follow-up visit over the course of 10 pages. This project is part of a study launched this past July, for incoming medical students on their first rounds. I believe in this instance, the comment comes closer to show, not tell, in regards to teaching's approach to students. In addition to bulleted lists and articles, we have a visualized diagram of interaction that plays in their minds in real time. Something I take seriously about being part of an educational institution is our part in molding the minds of the next generation of doctors. To another Star Trek reference. As times change, educators must change with them. And in order to teach in the modern age, we must use every tool at our disposal. I think social issues can be more easily addressed by a dynamic article that uses images and text together, such as a comic or short format. One that is constantly evolving and changing with times. It's not a replacement for essays and textbooks, but a supplement, and a way to engage more of the brain at a time. The breadth of topics we can address is extremely wide. Over the last few years, I have seen students from our medical commons workshop tackle ideas about medical misinformation, gender identity, aging and loss, motivation to enter the medical field, language barriers, accessibility, reproductive rights, body image, and much more. I'm currently in the beginning stages of public health comment project, illustrating patterns in healthcare as experienced by Black women in the United States over the span of 300 years. As someone who spent years working in the clinical setting, I saw firsthand how complex situations are, the many different facets there are to every case, and the work behind the scenes that it takes to run such large institutions. I believe that the more we understand about all of it, the better we can be. Comics are a great way to add to that perspective. I'm more convinced now than ever that this art form, graphic myths, can make an impact by fostering greater empathy in the healthcare setting and as an effective teaching tool for all generations.
See if we've got some questions. Over there.
Just a logistics question about how many hours did your comics work out per student?
How many hours? Well, we do 4 to 5 sessions of this workshop. The hours, it's about an hour, 2 hours long each time. So this is a voluntary workshop. So the students meet every other week and we go for about 2 hours each time. And it's only 4 sessions. And we do a lot of work offline. So Dr. Lutz and I are sitting in email communication. We have a shared drive. We help them craft their ideas together. So it's 15 hours, but it's way more than that, considering all the communication.